Trisomy 21 by Eileen, Lisa, and Mo. This is our table of contents. We will be discussing what is trisomy 21, patterns in probability, diagnostic testing, characteristics, gender differences, aging and puberty, immunizations, and anticipatory guidance. What is trisomy 21? Trisomy 21 is also known as Down syndrome. It is a genetic disorder caused by abnormal cell division, resulting in an extra full or partial copy of chromosome 21. This error in cell division is usually due to non-disjunction. The severity of trisomy 21 varies from person to person and can affect one's physical characteristics, intellectual abilities, medical abnormalities such as cardiac, GI, and more. Patterns and probability. The prevalence of trisomy 21 is approximately 1 in 500 live births in the United States without any screening, diagnosis, or pregnancy termination. The prevalence increases with advancing maternal age, which is referred to as maternal age-related risk. If there is no personal or family history of Down syndrome, the risk of Down syndrome is based on the maternal age at the expected date of delivery. For a couple with a prior conception with Down syndrome caused by trisomy 21, 95% of the cases are caused by non-disjunction, which occurs more frequently with advancing maternal age. Therefore, family members are not at risk as non-disjunction is not an inheritable trait. If the mother is less than 35 years of age at the time of diagnosis of non-disjunction, the risk of recurrence is approximately 1%. If the mother is 35 years or older at the time of non-disjunction trisomy 21, the risk of recurrence is the maternal age-related risk. If we look at a couple with a prior conception or family member with Down syndrome caused by an unbalanced chromosomal rearrangement or translocation, approximately 4% of Down syndrome cases are due to this. The most common translocation that causes Down syndrome is known as Robertsonian translocation, which involves chromosomes 14 and 21. Translocations can be familial or de novo, meaning it is the first occurrence as a result of a variant rather than a familial trait. When familial, the recurrence risk depends on the sex of the carrier parent. The recurrence risk is 10 to 15% for female carriers and 2 to 5% for male carriers. When de novo, the recurrence risk is based on the mother's age at the expected date of delivery. If the mother is less than 35 years of age, the risk is approximately 1%. If she is 35 years or older, the risk is equal to the maternal age-related risk. Lastly, let's look at a couple with a prior conception or family member with mosaic Down syndrome. A mosaic individual has more than one type of cell lining. This typically occurs as a post-zygotic error in mitotic cell division and it is not inherited. Therefore, family members are not at an increased risk. The recurrence risk is yet again the maternal age-related risk. Diagnostic testing. The diagnosis of Down syndrome is usually made by prenatal screening. If no prenatal screening is available, Down syndrome is usually recognized from the characteristic features present in the newborn that will be discussed later in the presentation. It is recommended that all pregnant individuals, regardless of Down syndrome risk, should be offered prenatal screening and diagnostic testing. There are different types of screening tests available based on individual recommendations. A screen-negative test result means that the fetus is at a low risk of Down syndrome as defined by the specific laboratory cutoff. A screen-positive test result means the fetus is at an increased risk of Down syndrome as defined by the specific laboratory cutoff. There are serum biochemical marker tests that assess the maternal serum levels of specific biochemical markers associated with Down syndrome. The first trimester combined test includes a sonographic determination of nuchal translucency and biochemical markers recommended for early diagnosis. The second trimester quadruple test measures various biochemical markers appropriate for those who first present for prenatal care in the second trimester. There are also integrated screening tests across the first and second trimesters that measure biochemical markers of Down syndrome in both the first and second trimesters, such as the full integrated test, serum integrated test, and stepwise sequential testing. Patients who screen positive in biochemical marker tests may undergo secondary screenings or diagnostic procedures to gather additional information. Another common screening test is the cell-free DNA test, which utilizes cell-free DNA in maternal blood to screen for common autosomal trisomies. This is a great option for patients with twin pregnancies, as the test failure rate is very low. There's very limited data on screening tools for pregnancies with more than 2 fetuses. Patients who screen positive for cell-free DNA in the first trimester should be offered invasive testing for definitive diagnoses. There are also several different diagnostic tests performed at various stages of the pregnancy. During the first trimester, a chorionic villus sampling is performed and a conventional karyotype is obtained. This can take between 2 to 10 days for results. During the second trimester, amniocentesis is performed to obtain fetal cells and a conventional karyotype is obtained. This can take 2 to 14 days for results. There are also several rapid tests used for diagnostics. The fluorescent in situ hybridization, or FISH, targets chromosomes 13, 18, 21, X, and Y. A quantitative fluorescence polymerase chain reaction, or QF-PCR, is a more recent rapid test technique used to detect trisomies of chromosomes 13, 18, 21, X, and Y. This test can be automated to allow for high throughput of samples.
Down syndrome is clearly the most common and recognizable genetic syndrome known, although at times the physical features may be difficult to identify in newborns and children. So let's go over some of the characteristics of Down syndrome in children and break it down. Short stature. This is one of the cardinal signs of Down syndrome. Then we have brachycephaly, which means that the back of the child's head becomes flattened. As you can see on the upper right picture, the back of the head becomes flatter as the condition becomes more severe. Then we have mid-phase hypoplasia with flat nasal bridge. In other words, they tend to have a flatter nose. There's also brush-filled spots, which are little white spots that are slightly elevated on the surface of the iris and are arranged in a ring. This is also a feature of Down syndrome, and studies show that they were detected in 67% of children with Down syndrome. We can also notice epicanthal folds with palpebral fissures that slant down to midline. As you can see in the picture on the right, individuals with Down syndrome have the outside corners of the eye that point upward. They also have a small mouth with protruding tongue. That means that they tend to have a large tongue. They also tend to have myopia. The prevalence of myopia in children with Down syndrome has been found ranging from 8% to 41%. They also have small ears. Children with Down syndrome, they have low set ears, and their ears are positioned lower on the head than usual. It has been found that some children with Down syndrome also have very narrow ear canals. They also tend to have short, broad hands and feet and digits, also single palmar crease and clinodactyly. And typically in other children, there are typically 2 creases in the palm, but those with Down syndrome, there is a single crease across the palms of the hands, and they develop while baby is growing in the womb, most often by the 12th week of gestation. Down syndrome children also present with short, stubby fingers with a 5th finger or pinky that curves inward, which is called clinodactyly. Then they also have exaggerated space between their great toe and the second toe. This is another physical finding in many infants with Down syndrome, where there is an increased gap between the great and the first toes. While this is a finding that can occur as a familiar trait, it occurs in constellation with other features of Down syndromes, and that if you see it, it will support the diagnosis. Other characteristics in children with Down syndrome is loose nuchal skin. This is abnormal skin folds over the back of the neck that can be a marker of Down syndrome. There's also congenital heart disease, particularly atrioventricular septal defect, which is the most common congenital heart condition in children with Down syndrome. In AVSD, blood is allowed to flow where it normally should not go. Blood can go to the lungs, where it gets oxygen, it can go to the heart, and then back to the lungs without taking the oxygen to the rest of the body. This is the most frequently diagnosed congenital heart condition in children with Down syndrome and is the main cause of death in this population during the first 2 years of life. And at last, children are also at risk for leukemia, Alzheimer's disease, and hypothyroidism. Now let's talk about some gender differences between males and females in the Down syndrome population. In males, the growth spurt happens later, around age 11, while females around 9.5 years old. As far as stature, males tend to be taller than females. They also tend to have higher chances of obesity than females. But as far as fertility and reproduction, nearly all males are infertile. However, females are fertile and they may become pregnant.
Stages of puberty for teens who have Down syndrome are the same as other teens. However, they require extra support such as talking about pregnancy, contraception, sex, sexual health, sanitary health for menstruation, family matters, relationship, personal, and social skills. They may lack in development of social maturity, emotional self-control, social communication, abstract thinking, and problem-solving abilities. They can marry if they're aged 18 years or older, as long as they can give consent. However, every individual is different in their capacity to give consent, make decisions, understand information, and communicate decisions. It's important to educate about what part of the body is private and how to stay safe. Teens who have Down syndrome are at risk for sexual exploitation and STIs. We also need to emphasize on differentiating private and public activities. Private activities can include masturbation. And we also need to educate the importance of HPV vaccine. Children with Trisomy 21 receive the same scheduled routine immunizations. However, it's important to provide influenza vaccine annually. Respiratory syncytial virus prophylaxis may be considered for children less than 2 years who have concurring qualifying conditions. Children with chronic cardiac or pulmonary disease should be given the 23-valent pneumococcal polysaccharide vaccine at 2 years of age or older. Children with trisomy 21 differ from the general population in their response to infection. They may be more susceptible to some infections, especially respiratory, because the differences in the structure of the ears and midface make ear, nose, and throat infections more problematic. The best way to reduce infections is by immunization. Influenza vaccine should be given every year before flu season, as children with trisomy 21 are more susceptible to influenza. For COVID-19 vaccines, they have been shown to be safe for individuals with trisomy 21 and effective in terms of resulting in minimal breakthrough infections and milder disease outcomes. Here's the anticipatory guidance for children with trisomy 21. Let's start with physical. For growth trend, we will be using Down syndrome specific charts. For feeding, we need to educate about adequate iron intake and giving dietary supplements. Also, we have to educate about preventing obesity with optimal dietary and physical activity. Also, early interventions is really important for these children, for such as physical, occupational, and speech therapies. Also, we educate importance of immunizations, independence with hygiene and self-care, preparation in understanding and managing puberty development, gynecologic care when they reach puberty, birth control and preventions of STIs, and the children with trisomy 21 are at increased risk for vision, such as refractive errors, amblyopia, for hearing problems,
resulting from otitis media with effusion, dental problems such as delayed or irregular dental eruption patterns, hypodontia, for respiratory risks such as obstructive sleep apnea, thyroid issues, cardiac defects, gastrointestinal problems such as celiac disease, neurologic such as seizures and myelopathy, and lastly for skin, psoriasis, alopecia areata, vitiligo, folliculitis, keratosis pilaris. For safety, we will educate the parent and the child about increased risk for sexual exploitation, and then also increased risk for spinal cord injury if they participate in contact sports. For psychosocial, we'll mention about methods of coping with long-term disabilities, strengths of child and positive family experiences, educate about support groups, current books, and pamphlets that may help the family, behavioral management, sibling adjustments, socialization, and recreational skills. Also to look out for behavior problems that can interfere with function in home or community or school, such as attention problems, ADHD, obsessive compulsive behaviors, non-compliance, or wandering off. Also, we will mention about individualized education program, appropriate school placements, and vocational planning. Lastly, for genetic, we will educate about chance of recurrence of Down syndrome in subsequent pregnancies and refer the parents to genetic counseling. Also, for female with Down syndrome, they have 50% chance of Down syndrome in their child. For male with Down syndrome, they will be infertile with rare instances of reproduction.
Here are our references. Thank you for listening to our presentation.